Hi, my name is Dr. Philip Phillip. I'm a professor of oncology. I also lead the GI oncology program at the Henry Ford Hospital. I'm privileged today to be joined by Dr. Tim Cannon. He's an associate professor at the University of Virginia, and he practices at the Innova Cancer Center. What we'll be doing today is go over case-based discussion. The focus will be on biomarker-driven treatments of metastatic colorectal cancer. So we start off with the case of Melinda. She's a 65-year-old woman with newly diagnosed left-sided colon cancer. She was found to have lung and liver metastases, and these were not amenable to resection or ablation. Her ECOG performance status was 1. So next she had a biopsy of the liver, which showed an adenocarcinoma compatible with colonic primary, CX20 positive, typical for lower GI adenocarcinomas, and CDX2 positive, again, which goes along with colon cancer. Again, the discussion here is that do we need to biopsy the lung also, or we're okay with just biopsying the liver? Dr. Cannon, can you provide an opinion on that?
I don't always biopsy all the sites of metastatic disease, but I do think it's important when the lesions are questionable or uncertain to be metastatic, because knowing how many sites of disease there are may alter your strategy for more directed therapies, particularly with liver-directed therapy. So, I think in a case where you'd consider liver-directed therapy, if it was liver-only disease, you'd certainly want to get a biopsy of ambiguous-looking lesions in the lung. In the absence of that, I wouldn't always necessarily pursue it, given the risk of pneumothorax or some other problem from the biopsy. Is that consistent with what you would do, Dr. Phillip?
Yes, that's exactly right. Yeah, that would be. And in this patient, the lung metastases were multiple and extensive. So the NCCN guidelines for biomarker testing in colorectal cancer, the NCCN recommends that all newly diagnosed patients with colorectal cancer should receive MSI or MMR testing. And all patients with newly diagnosed metastatic colorectal cancer should also get KRAS, NRAS, BRAF, or PANRAS mutation testing. It can be done either as a focused or individually intended testing, or part of the NGS-based multi-gene panel, which is being increasingly used by physicians. Testing for HER2 overexpression and NTRK fusions are also recommended because we have now drugs that can be targeted to these abnormalities. It can be done individually by immunohistochemistry, FISH, or as part of an NGS-based multi-gene panel. The HER2 testing at this time is not recommended in patients who have either RAS or RAF mutations because of obvious reasons. They don't coexist. It's very rare for them to coexist because these are driver mutations, and the tumor cell has one driver mutation usually. Testing can be performed on formalin fixed or paraffin embedded tissue, although the paraffin embedded tissue is really preferred. And also nowadays we can do circulating tumor DNA, leading to into looking into any of those mutations, and this is what we call the blood-based assays. So, Dr. Cannon, how do you really look into incorporating these tests, and how do you decide, and how do you make recommendations to for your patients, but also how do you make recommendations for the colleagues who come to you and discuss how to optimize a test, especially in tumor boards when there are such discussions?
Right. This is a good question, something I think about all of the time, and I agree with your general overview. I think that for 90% or more of your colon cancer patients, the important clinical information can all be obtained through a PCR-based test. In the first line, where you're just starting to treat a new patient, the KRAS, NRAS, and BRAF information, along with the MSS status or the MMR status, is what's crucially important, because that will affect what you do from the beginning. Of course, with the Paradigm trial and Keynote trial that supported the use of immune checkpoint inhibitors in first-line therapy. Those are the important point of care decisions that you'll make with patients at their first meeting. However, I also send the multi-gene panel because it sometimes can be incredibly impactful. And in my experience, we get those tests back more like in the 2 to 3 week range. But I've had certainly several patients for whom that information has been very illuminating. One example is of a patient I saw this week who had a ROS1 fusion in her colon cancer. And I've been following her for 1 year on a clinical trial, the ASCO taper trial, where she's on entrectinib, and it's been incredibly impactful. So, for those rare, and you had mentioned that a lot of these multi-gene panels have RNA, and so you're more likely to detect fusions in those panels with RNA. And so, that was the case with this patient. It was incredibly impactful. So my usual strategy is to get the PCR-based tests that are listed on the left: KRAS, NRAS, BRAF. Do IHC for HER2 staining, because those are things that can all be done at our pathology department. And I can get those back within a week. And then with the tissue that's left over, I will typically, even while they're on first-line therapy, get a multi-gene panel. There have been times where there's a little nuance to this. For example, if the patient's path is outside, maybe they're from Alaska, but they came to visit their kids in Virginia. Actually, in that case, sometimes rather than trying to get it to our pathologist to analyze it and order all the tests, it's sometimes easier just to order one of the multi-gene panels, because those companies are everywhere, and you'll probably get the results of KRAS faster that way than you would, if you tried to get the biopsy and do the PCR-based test in your own lab. But by and large, I'm doing PCR-based first, and then the multi-gene panel with whatever tissue is left over.
And I agree with you. Those patients who come from somewhere else, and I see a fair number of them, it's easier just to do the NGS and get on with the treatment. Now, let me ask you this, Tim. What about the liquid biopsy? Does that have any place or indication within your, you described everything extremely well. Is there a reason why sometimes you will use liquid biopsy at the outset? These are patients who, yeah.
So that's a great question, and I'd love to hear your philosophy on that. I typically do not do that unless I didn't have enough tissue to do the multi-gene panel, because I haven't really felt that there's added value in colon cancer. Now, of course, there's special circumstances where we may get, if we're doing a targeted therapy, for instance, in the case I just told you about with the ROS1 fusion, we're seeing, if the fusion was detected in the liquid biopsy and you can follow the allele fraction over time, there may be some value there. But otherwise, I don't do those panels for the purpose of looking at the mutational profile. If we're referring to ctDNA, that's another story, and I have started to do that. But for a sort of what we usually refer to as the liquid biopsy, just to look at the different variants, I haven't usually done that in practice.
Yeah, no, I agree. That would be also my practice. I don't do it for that particular reason, but for following up the patient disease activity, yes, ctDNA. Yeah. She had NGS-based multi-gene testing, and this showed BRAF V600E mutation, KRAS wild type, NRAS wild type, and microsatellite stable. And the tumor mutation burden was 30 mutations per megabase. Now, just a bit of information on BRAF mutations and metastatic colorectal cancer. It affects 8 to 10% of the patients we see. 80% of them are BRAF V600E mutations, which are the ones which obviously we'd like to see because we have targeted treatment for them. We can discuss what happens to the other mutations. These tumors usually present with bulky, aggressive, right-sided tumors with frequent peritoneal metastases, and they have worse prognosis when we compare them to the wild-type genotype, and also when compared to the non-V600E mutations. The median overall survival is said to be 11 months, but again, this can change with the newer treatments. They tend to have poor response to standard cytotoxic chemotherapy, and the presence of these mutations also can predict resistance or poor response to EGFR inhibitors, which is very important because obviously these patients present with wild-type KRAS, which may be a reason why some people may consider using EGFR inhibitors. And as I mentioned, they are mutually exclusive with the other oncogenes, KRAS and NRAS. Dr. Cannon, can you discuss on the issue of triplet chemotherapy use? Obviously, we're talking about FOLFOXIRI in this situation compared to using either FOLFOX, CAPOX, or FOLFIRI.
Yeah, going back to as early as 2014, to the best of my memory, there was some data that FOLFOXIRI was more effective in BRAF mutant cancer, and I've certainly experienced, in my own practice, a lack of responsiveness to doublet chemotherapy. So, for the healthy patient that's able to tolerate it and is in a good position for chemotherapy, I've tended to give triplet chemotherapy. Although certainly there's a high percentage of patients that aren't fit enough or have a high enough performance status to get triplet chemotherapy. I find that no matter how you give it, the chemotherapy tends to be effective for a very limited time, and the more impactful types of treatments are what we're going to discuss next, with the directed therapy.
Obviously, one thing one can mention here is that there are clinical trials, at least there's one large phase 3 trial in the front line, and these patients may be put on those trials. But again, one of the limitations is that do you get the data on the BRAF status early on to be able to put someone on a clinical trial and not wait that long to have someone on a clinical trial. So she received FOLFOX plus cetuximab as first-line therapy, responded for 10 months until disease progression. So the question is, upon disease progression, what will be your next line of treatment? Just a brief overview of signaling in patients who have BRAF mutations in metastatic colorectal cancer. The key thing is that single-agent treatment with a BRAF inhibitor didn't really work because of what we call adaptive resistance, because it really leads to the firing of the EGFR signaling pathway, which overcomes the ability to block the BRAF, which is downstream of the RAS. So as a result of that, studies have looked into combining anti-BRAF treatment plus an anti-EGFR therapy. This ultimately led to the Beacon, which is a phase 3 trial. And in this study, which was limited to patients who have BRAF V600E mutation, who have progressed after 1 or 2 prior lines of therapy, who had no other mutations or received EGFR inhibitor, they were entered into the trial receiving either a triplet, which included encorafenib, binimetinib, and cetuximab, or a doublet, encorafenib, cetuximab, or the control arm, which is FOLFIRI plus cetuximab or irinotecan plus cetuximab. The idea here was to really build on the initial data where cetuximab was needed, but also to see whether a double hit on the pathway using bimitinib, which would be providing a better control of the signaling blockade through this pathway. And on the right side of the slide, you can see that the results were as follows. The median OS was 9.3 months in both the triplet and the doublet, and the control arm was 5.9, so the hazard ratio was 0.6 for the triplet and 0.61 for the doublet, very similar. If you look at the median progression-free survival for the doublet and the triplet, were again similar with a very decent hazard ratio of less than 0.5, but the control arm didn't do well. 1.5 was the median PFS. And then they looked into another category or subcategory of the BRAF mutations, patients who have MSI high. There were just over 30 patients who had that, and there was no benefit to the doublet treatment compared with chemotherapy. If you look at the patients who had differences in other parameters, there wasn't really anything which stood out. So I would like to ask you, Dr. Cannon, what are the best ways or practices for dealing with the toxicities? And also, can you comment on, in your practice, do you involve the palliative care specialist at this juncture while you're treating a patient in the second or third line, and especially when you use drugs that can cause side effects?
Yeah, and again, I'd love to hear your take on this. I think, first of all, because of this toxicity difference and the relative equivalents of the triplet and the doublet, I think most people around the country give the doublet therapy. And that does cut down on some of the toxicities. That being said, the dermatitis is always a big concern for patients. And we're fortunate enough to have a dermatologist that focuses on dermatological toxicity from oncology regimens. So she sees all of our patients actually just as they start to receive EGFR antibodies like cetuximab and panitumumab, and generally starts everybody on an antibiotic such as doxycycline or minocycline, and gives topical steroids, sometimes gives topical clindamycin, and then monitors them throughout their course, sometimes adding moisturizers or sometimes even newer agents like interleukin inhibitors. So that's how we do that. As far as palliative care goes, I think it is a great idea to do that early, and I've seen the benefits of that. If you're at a center where the palliative care team has the capacity to see, every metastatic patient, I think this is a subgroup of patients that really does benefit from palliative care, given some of the toxicities of the treatment and also the poor prognosis.
Yeah, I agree with you. I mean, in the previous center I worked in, they called it supportive care, which was a bit more like acceptable in terms of palliative care can have it. But I'm a strong believer in supportive care or palliative care because I also believe that it can help patients not only have better quality of life if we can control some of the troublesome symptoms or side effects, but also patients stay on treatment longer. Sometimes we will give up treatment if it has a lot of side effects. So to me, it's patients with advanced or stage 4 disease of any cancer type, I think it's also always a good idea, and I agree with you. And the dermatological management, which you mentioned, is pretty much what we do. And I'm glad that you have a dedicated or someone who's really easily accessible for those patients. I'm going to go over the NCCN guidelines regarding the management of patients with RAS or BRAF mutations. This is very familiar to all of you because you deal with this every day in your practice, the KRAS, NRAS mutations. And we don't use the anti-EGFR treatments because of the resistance. And here you're also including the BRAF, as we discussed earlier. Patients have BRAF V600E mutation. Then we have a doublet that is approved by the FDA. And again, for patients who had received prior lines of treatment 1 or 2. As some of you may remember, there was a SWOG trial of cetuximab, irinotecan, and vemurafenib. That was part of the recommendation, but now they're not included in the guidelines. The same thing with the dabrafenib and trametinib. So what is the next option for this patient after progression on the encorafenib and the cetuximab? The question becomes, is she a candidate for an immune checkpoint inhibitor based on the TMB result? And should we repeat molecular testing upon progression, in this case, encorafenib and cetuximab? And is this really where you want to use liquid biopsy? We can discuss this, and I'll ask Dr. Cannon maybe to have a shot at it.
Sure. So, I think that given the poor response to chemotherapy in first line, you're hard-pressed to give a different chemotherapy after failure of encorafenib and cetuximab. There have been times where I've given just a combination of BRAF and MEK inhibition, like we did before the Beacon combination came out, such as trametinib and dabrafenib, which is approved by the FDA. In this case, she would be a candidate for an immune checkpoint inhibitor based on the TMB result. Now that, of course, the approval for pembrolizumab is for anyone that has a tumor mutational burden over 10. I've often wondered if that cutoff is appropriate because I rarely see a big benefit for patients that are in that sort of 10 to 20 cohort. But for the MSS patients that have really high tumor mutational burdens, like over 20 or 30, I do fairly consistently see clinical benefit. Nonetheless, because even some patients at the lower range will get a benefit, I think that would be worthy of a consideration, particularly if she's feeling beat up from side effects from the previous regimens. As far as the third question about molecular testing being repeated, I think this is something that's really interesting for the purpose of research, looking at what the mechanisms of resistance are. The issue is just that it's so rarely targetable that I haven't found it to be really useful in clinical practice. But I'd love to hear what you think about that, Dr. Phillip.
Yeah, I'll start with the third point, and I agree with you. It has been suggested in patients who receive anti-EGFR treatment, maybe you can look at the emergence of new clones, etc. But I don't think it's going to be helpful in a situation like this. Again, unless it's part of a research hypothesis-driven testing where you really want to prove or disprove something. In terms of the immune checkpoint inhibitors, that's something which would be a very reasonable option. My question would be, would you be using a Pembro or you would be using a Ipi/Nivo? What would be your preference here?
Because pembrolizumab is, what was approved for the TMB over 10, I think that would be the option that would be feasible from sort of a payer and practicality standpoint. Obviously with the MSI high population, I am tempted based on the results of Checkmate 142 to give Nivo Ipi, but for this kind of situation, I've only given pembrolizumab myself.
So this is to confirm that we would prefer the Pembro in a situation like this, because sometimes it comes up, people asking questions, what about Ipi/Nivo? But that's something which, at this point, at least in my practice, is limited to the MSI high patients, I agree. And again, further chemotherapy in this lady is not going to really help. Question becomes, what about Stivarga or even TAS-102? We heard the phase 3 trial of TAS-102 plus bevacizumab last week. So these might be also options, I guess, but we're also limited by their activity. And if she's symptomatic, we may need to do immunotherapy, as immunotherapy will be probably the next step in my practice also.
Case 2 is about Steve. Steve is a 72-year-old man with newly diagnosed metastatic colorectal cancer. He has lung and liver metastases that are not amenable to resection or ablation. So really, we're focused on systemic therapy here. He has a reasonably good performance status with an ECOG performance status of 1, and he has no family history of colorectal cancer. You can see the biopsy here that shows strong staining for CDX2, confirming a colorectal primary. Of course, one of the first steps that's done in pathology departments throughout the country and the world is to get MMR, mismatch repair, immunohistochemistry. And you'll notice that he has MLH1 and PMS2 are absent. So this is a deficient MMR tumor. This is a pattern that's very common since MLH and PMS2 are partners. And typically there's secondary loss of PMS2 when MLH1 is lost. He had NGS-based multi-gene panel testing and was found to be BRAF wild type, KRAS wild type, and NRAS wild type. He was determined to be microsatellite instability high. So this is an MSI high tumor. His tumor mutational burden came out to be 12, which from my perspective is uniquely low for an MSI high tumor, but still certainly higher than the average MSS tumor. All right, so what is the next step for this patient? We know he has metastatic unresectable colon cancer, and it is MSI high. What would be your next step, Dr. Phillip?
I don't see anything more we need to do before we plan on giving him treatment. Am I correct?
I agree. As far as an overview of deficient mismatch repair in colorectal cancer, it occurs in about 15 to 20% of colorectal cancers, a little more common in colon cancer and less common in rectal cancer. Generally, the mismatch repair occurs from the loss of MLH1, MSH2, MSH6, PMS2, or EpCAM. As I mentioned before, MLH1 and PMS2 are partners and they form heterodimers, which means when you lose MLH1, you will often lose PMS2 as well. The inverse is not true. PMS2, when lost, will usually be lost by itself. Similarly, MSH2 and MSH6 form heterodimers. On biopsy or resection specimens, we do IHC to look for loss or absence of these proteins. So remember, the initial test is not looking at the gene itself, it's looking at the protein expression in the tissue. They shouldn't be reported as positive or negative, but rather, in our system as a percentage of the specimen that stains positive. It's important for quality control to confirm that internal positive controls are present. So the bottom bullet says common causes of protein expression loss, and I think this is an important point. Of course, many of these MMR deficient tumors are associated with Lynch syndrome, which means that the person was born with a germline mutation of one of the genes that code for MLH1, MSH2, MSH6, PMS2, or EpCAM. There are other reasons, though, that people can have MMR deficient tumors with protein expression loss. One of those is an epigenetic event, meaning something that's not in the DNA, but rather as a result of how it's transcribed to RNA. And that's most commonly an MLH1 promoter hypermethylation. So this often happens in sporadic tumors and is not a result of a germline genetic deficiency, but rather something that happened during the patient's lifetime. And it won't be reflected in the NGS genetic evaluation, but rather on a special test that evaluates for promoter hypermethylation. You'll notice that a lot of these terms are used interchangeably. Sometimes we call it Lynch syndrome, sometimes we call it MMR deficient, sometimes we call it microsatellite instability, and it sort of reflects the test that you're doing. Again, remember, Lynch syndrome only refers to the germline deficiency or a genetic mutation, inactivating mutation that results in inactivation of the proteins that perform mismatch repair. Microsatellite instability is really a description of how you do a test to test for mismatch repair deficiency. Microsatellites are short, highly polymorphic tandem repeats of DNA found throughout the genome, and they're very prone to replication errors. So testing for the amount of errors that occur in those microsatellites is an excellent way to test for mismatch repair deficiency. PCR-based tests detect the proportion of insertions or deletions in predetermined microsatellite loci. A number of positions of the loci measured vary by commercial test and can involve di or mononucleotides, and the test results are reported in a binary fashion, either as microsatellite stable or microsatellite instability high. MSI high can also be detected by an NGS-based sequencing, so it should come out when you order from any of your commercial NGS companies. Dr. Philip, when you already know from IHC that the patient is microsatellite or mismatch repair deficient, do you get the NGS test?
I do, but that's part of my the way I manage the patients, and I because I look at the other mutations that I'm trying to find out whether the patient has. What about yourself?
Yeah, I do as well. Occasionally I've noticed discrepancies between the tests where there's an absence of a protein, and then when you get the NGS, everything phenotypically doesn't seem like MSI high cancer. The normal mutational burden, we don't see any mutations in it, and the hypermethylation. I've always struggled. That's happened a couple of times this year, actually, and I've struggled with what to do other than just repeat the tests. Have you ever come across that situation?
Yeah, I think the number is probably 5% or around that, where you will at least 5% where you will see a discrepancy. The question becomes what is important, the NGS or the protein. And if you think of it, if the protein is really doing the function and it's not there, I would certainly respect the IHC. That's the way I would probably look at it.
Right, that makes sense. Right, there's numerous reasons why the NGS may not pick it up, and if the protein's absent, yeah, that makes sense to me. I've also heard, though, that occasionally you can the IHC is testing for an epitope that the patient doesn't have, and so sometimes you can have the inverse where the IHC doesn't catch it, and then you catch it on the NGS.
Yeah, that can happen also. Yeah.
As far as diagnosing Lynch syndrome, which again is the germline deficiency in mismatch repair proteins, 90% of Lynch syndrome patients are MSI high. 10 to 15% of sporadic colon tumors are MSI high and show abnormal MMR results, usually MLH1 loss. And the loss of MLH1 protein increases the probability of Lynch syndrome, but again, it's not definitive. There are other reasons why you can have loss of MLH1. So once you have that abnormal MLH1, like in this patient case that we showed before, you want to do germline genetic testing. That is an absolute must. You've got to send the patient to a genetic test counselor or if that's not available, at the very least, order germline testing. You should order, and most places this is done reflexively, but if it's not, you should make sure that MLH1 promoter methylation testing is done, and also BRAF V600E testing, which is disproportionately associated with MLH1 promoter methylation testing. I don't know the landscape, Dr. Phillip. Is MLH1 promoter methylation generally done reflexively almost everywhere, do you think?
Well, I can tell you from my institution, our tumor board, and we have a robust, dedicated tumor board, we do ask them to do the MLH1 testing because I don't think it's necessarily done reflexly. And what I'm trying to say is that for the providers, for the clinicians, oncologists and surgeons, I think it's a good idea just to make sure that they request it, because I don't think it's uniformly done as a reflex routinely.
As for the association with BRAF V600E mutations and Lynch syndrome, 69% of MLH1 methylated CRCs carry the BRAF mutation. And BRAF V600 is quite rare in Lynch syndrome. So if you see an MSI high phenotype and a BRAF mutation in your NGS, you suspect that this may be not related to Lynch syndrome. So again, in that cascade of events that you do, or the cascade of orders that you do after you see loss of MLH1 sequencing and you get your methylation assay, you certainly want to make BRAF V600E testing a part of that, because it's a very cost-effective way to distinguish and rapid way to distinguish between sporadic colorectal cancers from Lynch syndrome when MLH1 or PMS2 are reduced or absent. So if BRAF testing is done by itself and is normal, again, consider MLH1 promoter methylation testing as well. I mean, a lot of times, I think practically speaking, you just ask for both of these simultaneously, BRAF and MLH1 promoter methylation. And then, of course, you're always asking for germline testing and a genetic evaluation where you're testing, the blood or the saliva or something that's not in the tumor to confirm that this patient has Lynch syndrome, or see if they have Lynch syndrome and that MLH1 is missing in all of the tissue. And here it says the overall goal is to decrease referrals to genetic counseling. And I think that goal may make sense in some centers, where there's a mismatch between supply and demand. But in other centers, it's encouraged to get genetic counseling. Would that be, is that the way you'd characterize it, Dr. Phillip?
Yeah, I fully agree with you. And for some reason, during COVID, it became even more difficult to get patients. I personally, we do the mouth swab test, one of the vendors, so it's easy, like we can do it and get it done quickly.
All right, so this is sort of the way we think about Lynch syndrome testing results and how to test. And you see in this patient, he was missing IHC for MLH1. It was absent on his IHC staining. He then did a BRAF analysis, and there was no BRAF mutation. And he didn't have a suspicious Lynch syndrome age or history. And so an MLH1 methylation test was done, and that was apparently not present. So you can see that lower box. It says if germline mutation, then Lynch syndrome. If no germline mutation, consider testing for somatic MMRG mutations. And that does happen fairly frequently. They don't have Lynch syndrome, but MLH1 became mutated in this clonal cell population during the patient's lifetime, and they have an MSI high tumor. What is the guideline recommended preferred first-line systemic therapy for this patient? Dr. Phillip, what do you typically do in first line?
In my practice, I will be using pembrolizumab based on the Keynote trial. And I use a single agent immunotherapy using pembrolizumab. I have no experience with the dostarlimab, which you have it here, and the nivolumab, ipilimumab, I use it more in the second line or third line setting. However, I give an example of a case recently, like 2 days ago. My colleague said there's a patient who is young and has a platelet count of only 10,000, and the patient has colon cancer metastatic to the bone marrow. That's why you're getting that bad of a situation in the platelets. And the question was, do we use pembro in that urgent situation, or we use nivo-ipi, where you think that it may have a better response rate or I wouldn't say quicker necessarily, but better response rate. But my idea was that the Pembro study was a phase 3 study. The response rate was based on a phase 3 trial. Ipi/Nivo was a more limited trial, it was phase 2, so it's difficult to say. I think Pembro is as good as anything in the front line.
Thanks, Dr. Philip. And yeah, that would be my practice as well. Since we have randomized controlled data on pembrolizumab. Here's Keynote 177, which we were mentioning before, where pembrolizumab was randomized to chemotherapy in the first line for MSI high tumors with an overall response rate that was 44 versus 33%, and a progression-free survival that was more than double the chemotherapy arm. In the subgroup analysis, the hazard ratio for BRAF wild type, BRAF mutant, KRAS and NRAS wild type were all quite low, whereas the KRAS and NRAS mutant tumor population, which the N was not very high, but the hazard ratio was 1.19. Checkmate 142, which I mentioned before, is the doublet therapy. It was a phase 2 open label trial. It was randomized. Sorry, it's phase 2 randomized trial, nivolumab and ipilimumab versus nivolumab. And the response rate was 55% in the nivo-ipi arm, and 12-month overall survival was 87. And this past June at ASCO, they reported out the longer-term results, which I mentioned showed progression-free survival over 4 years. Of course, there are many upsides to immune checkpoint inhibitors, including these great response rates and survival numbers in MSI high colorectal cancer. And, in balance, I think we'd all agree that it's generally easier to tolerate than chemotherapy, but when the side effects come, they can be very serious and frightening. And here's a list of some of the more common ones. Of course, for us, probably the most dreaded and common one with nivo-ipi is colitis, but several other of these side effects can be really severe. And of course, it's always important to review the NCCN guidelines or the ASCO guidelines for management of immunotherapy related toxicities and to follow them closely. Metastatic colorectal cancer tumors are enriched for rare fusions, and you see on the top line some of the fusions that we really focus on in a lot of different cancers, particularly lung cancer, like ALK, ROS1, RET, and NTRK fusions do occur, ranging from 0.2% to 2.4% of all colorectal cancers. But they're enriched in RAS and BRAF wild type tumors, of course, because there has to be something driving those tumors, and MSI high tumors as well. They're also enriched in older patients with right-sided tumors. Now, I don't know if I feel that comfortable with this bullet point about them being associated with poorer survival, because that's based on kind of a small retrospective study. And sometimes if they're targetable, like in the patient I mentioned earlier with the ROS1 fusion, they can have very long survivals. They may predict primary resistance to anti-EGFR antibodies. We know that's, of course, the case with KRAS mutations and HER2 amplification. They potentially confer sensitivity to RTK inhibitors. And, in the case that I talked about with the ROS1 fusion, the patient was getting entrectinib. Here are some of the RTK inhibitors for ALK, ROS1, RET, and NTRK, and I think we're all familiar with those. NTRK fusions in cancer are infrequent, but incredibly impactful when you find them. The overall prevalence was 3 out of 1,000 in a database of nearly 300 or of about 300,000 patients. NTRK can come with many different fusion partners, and 88 have been described as far as we know. But as long as it's something that a fusion that results in retention of the activation sequences, the kinase domain, and promotes that feature, and if they're reported in NGS, they're usually going to be activating mutations that can be incredibly impactful and very targetable. Dr. Philip, have you ever found an NTRK fusion colon cancer?
2-3 years ago, we had one patient, and the patient was on treatment for approximately 10 months. So again, compared to what you can do with chemotherapy and like third, fourth line treatment, compared to what you can do with the other drugs we have, like regorafenib or TAS-102, it's certainly a very durable response that you get with them. And it works quickly. It doesn't take that long to work.
And here's some of the history of NTRK inhibitors with incredibly high response rates, but colorectal cancer is represented a relatively small number of the patients. one of those 4 CRC patients in the larotrectinib trial was somebody I treated who did not respond. That's the only one I've seen. So a couple of questions here as we finish this case. Should this patient receive NGS-based testing to look for other alterations after progression on pembrolizumab? And I assume the intent of the question is to ask, should it be done again? What do you think about that, Dr. Phil?
The NGS testing, repeating it, I personally, I don't feel strongly about it, because possible you pick up something, but the chances are extremely, extremely low. I have done it occasionally, but I never got encouraged to do further based on my experience and based on other people's experience, unless you tell me something different.
I can't tell you anything different, right? Exactly. And one of the concepts I just want to bring up is, when it's MSI high, you have a list of about, 50 to 100 mutations a lot of times that are, before you even get to the variant of unknown significance section. And so I always kind of wonder, if I'm targeting one individual mutation, how likely that is in an MSI high patient to really be helpful. And maybe that's sort of discouraged me from continually doing NGS, in an MSI high patient.
No, I agree. I mean, one thing even we could touch on is those patients who have like BRAF mutation, for example, and there's targeted therapy. We don't treat the BRAF. We treat the MSI high. Our treatment is based on that. But again, patients who have MSI high, they tend to have a lot of mutations, as you rightly said, and a lot of these mutations, maybe all of them, are just I don't know how to describe it, but non-driver mutations. They're not like biologically impactful mutations. I've seen BRCA2 mutations. I've seen lots of things which, I mean, it's great if they were the only mutations I see in some patients, but part of that long list you mentioned, I do not think there's any merit in treating them. So that's the reason.
Right. It's kind of, it seems like they probably are late events,
Yeah.
in a tumor that's just, can't
Exactly.
mismatches.
Exactly.
So here are the NCCN guidelines for recommended molecular biomarkers and associated therapies in CRC. So we've kind of covered a lot of these. Obviously, you don't give the EGFR antibodies and RAS mutations. You see BRAF V600E recommendations, MSI high recommendations. We talked about TMB over 10 and HER2 amplification. We didn't talk about a lot today, but in the 3 to 5% of colorectal cancers that are HER2 amplified, there are multiple treatment options, trastuzumab combinations among them. Of course, there's a lot of excitement about trastuzumab deruxtecan now, based on the DESTINY trial in colon cancer. NTRK fusions and RET fusions are also of our interest. Key takeaways: the NCCN guideline recommended biomarker testing for CRC includes an assessment of mismatch repair deficiency, checking for KRAS, NRAS, and BRAF mutations, HER2 amplification, and NTRK fusions. Now, of course, I usually get that through the NGS testing, but I think there's multiple ways to do that. For BRAF V600E mutated colorectal cancer, when chemotherapy is appropriate in the first line, a doublet or triplet could be considered. And in the second or subsequent lines, based on the Beacon trial, encorafenib and cetuximab is a standard of care. And then from our last case presentation for the MSI high colorectal cancer, of course, you need to evaluate for Lynch syndrome, and if there's MLH1 loss, evaluate for MLH1 promoter methylation. And the best randomized data is for pembrolizumab monotherapy. But of course, Checkmate 142 makes Nivo/Ipi an attractive option in some cases, even though the level of evidence is not as high. Later line options may include these other agents. Of course, there was a lot of excitement from patients based on the results, the late-breaking abstract at ASCO for localized rectal cancer to give dostarlimab. But currently, the standards for MSI colon cancer in the metastatic setting is pembrolizumab and possibly Nivo/Ipi. And of course, for our rare NTRK fusion positive tumors, later line entrectinib or larotrectinib is appropriate. Thank you very much, Dr. Phillip. I appreciate all your comments and all I learned from you today. Thank you.
Thank you. Thank you. And I really enjoyed our discussion.